Hello, everyone, and welcome to today's Triple Tree Thought Leadership session. Before we get started, I'd like to go over a few items to help you get to the most out of today's session. You've joined the presentation listening using your computer speaker system by default. If you'd prefer to join over the telephone, just select phone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's panelists by typing your questions into the question pane of the control panel. You may send in your questions at any time during the presentation. We will address questions throughout today's discussion. I'd now like to introduce Michael Carroll.
Good morning and welcome to Market Insights Live. My name is Michael Carroll and I'm the Chief Marketing Officer at Triple Tree. Today's session is focused on primary care and the innovative approaches creating new opportunities for payers and providers to manage benefits, risk, and costs. A reminder that the views and opinions expressed in today's discussion are those of our participants and do not necessarily reflect the official position of Triple Tree, TT Capital Partners, and its affiliates. To begin today, I'd like to introduce today's panelists. First, I'd like to introduce Andy Altorfer, CEO and co-founder at CirrusMD. Since co-founding CirrusMD in 2012, Andy has grown the business into healthcare's leading text-first virtual care platform. During this journey, CirrusMD now serves more than 10 million people. Andy, thanks for joining us today.
Yeah, thank you for having me. Appreciate it.
Next, I'll introduce Dr. Christopher Crow, CEO and co-founder at Catalyst Health Network. Under Dr. Crow's leadership, Catalyst is the first North Texas physician network to hold value-based contracts with the 4 largest leading health insurance companies. Catalyst is an accredited, clinically integrated network of primary care physicians with more than 1,000 primary care providers and over 300 office locations. Chris, thanks for joining us today.
Good to be here. Thanks.
And next, I'll introduce Roberto Palenzuela, CEO and founder at ClareMedica. Roberto is a senior healthcare executive and operator with more than 25 years of experience. Under his leadership, ClareMedica provides patient-centric care and coordinates comprehensive healthcare services for Medicare Advantage, Medicaid, and other customers through a network of employed and affiliated physicians in the Florida market. Roberto, welcome.
Thank you. Happy to be here.
And finally, I'll introduce my colleague, Michael Huey, Senior Director at Triple Tree. In his role, Michael is focused on new business development, client engagement, and transaction execution. Michael specializes in healthcare services and technology with a focus on managed care, care delivery, multi-site care, and payer-provider collaboration, along with other healthcare sectors. Michael, I'll turn things over to you to get today's conversation started.
Great, thank you, Michael. Again, I'm Michael Huey, Senior Director at Triple Tree. I'm excited to bring this panel discussion today on 21st century primary care. Thank you to all 3 of our participants. Before we dive into the discussion, I just wanted to say a few words of context to set up the conversation. Next slide, please. First, as is absolutely no surprise to anyone in our audience today, primary care is truly the cornerstone of not just value-based care, but more effective care delivery in America, period. Everything from prevention, just given the frequency of the conversation between primary care physician and patient and the intimacy of that relationship, that the physician and the physician's office is better suited to help avoid the onset or the progression of disease. Furthermore, the physician and the physician's office and staff are well suited to help the patient navigate what is often a tumultuous journey through the system. Those decisions, which the primary care physician's office has great influence on, greatly impact the ultimate outcome, both in clinical outcomes as well as cost. Next slide. For today, we're talking about 21st century primary care. And what does that mean? Well, frankly, it doesn't mean just one thing. There are a variety of next generation care delivery models, as we coin them. Some examples, everything spanning from senior focused care delivery, physician-based care delivery into the home, care that's organized in value-based care arrangements, care that's centered around chronically ill, institutionalized individuals, behavioral health, which is increasingly and importantly integrated with physical primary care, as well as virtual health capabilities. But quite frankly, the importance of 21st century primary care is not to just deliver care through any one of these siloed models, but to frankly better integrate and collaborate across all of these. We're going to talk a lot about that today, as well as the tools and resources that help the primary care physician do his or her job even more effectively. Next slide, please. So, as is no surprise, all of this interest is driving a lot of activity in the investment markets, with primary care receiving considerable attention from the market, both in the form of private equity investments in longstanding platforms to help them scale nationally and affect a much larger patient population, but also investments from private equity, venture capital, and even strategic firms into upstarts that are really innovating care delivery. And then on the right-hand side of the page, what's been fascinating to watch is, and these are just a few representative examples, but now the public markets are now interested in primary care, with numerous examples that have gone public either through IPOs or through mergers with special purpose acquisition companies. It's a real bellwether for both the clinical good that primary care does, but also the investment opportunity. And I think what's important, and what we'll talk about today, is how the investment dollars coming into this space can really fuel continued innovation and build out of additional resources, tools, and technology that, again, make that physician's job even more effective. Next, please. And lastly, just a recurring theme throughout TripleTree's Market Insights slides, we'll talk a lot about the technology and tools that go into virtual health, weaving everything from the initial intake to the actual care delivery and to home-based monitoring and remote touch points with the patient. All of this enables, we really think, the future of comprehensive care delivery woven into the fabric of the existing clinic-based interaction. With all of that as context, I'm excited to jump in. So what's great about today's discussion is we have three leading companies from across the primary care space. Each company really enables or delivers a different mode of primary care, which I think is going to bring a lot of richness to the discussion. So with that, let's jump in. So let's start with, here we are in 2021, and we've just been through obviously a very tumultuous year in healthcare as a society writ large. Why don't we start with how has this year of COVID and other changes, how has that changed very drastically the expectations of consumers, of providers, of payers, whether they be health plans or employers? Let's start with that topic. Andy, let's start with you. CirrusMD works with payers and employers predominantly, and we believe we've seen a market shift in their interest in actually better leveraging and more proactively leveraging virtual health capabilities. What are you seeing happen in the marketplace?
Yeah, Michael, I mean, it's been a really, really interesting 18 months or so, in that the way the, at least payer landscape, payers including both the insurers and the employers, are viewing access options has changed radically. Here in Colorado, 80% of the brick and mortar primary care practices were shut down over the course of the last year. So people really didn't have anywhere to go. And that created a really interesting dynamic. I mean, are you going to go to emergency care, or are you going to go virtual? We saw a massive uptick. I mean, we literally quadrupled volume overnight as COVID really started becoming prevalent here in Colorado. And, we work nationally, we're in all 50 states. And it's a very fascinating thing, but it happened really quickly. And we were able to manage that demand with sub 60-second response times across the board, connecting patients directly to a doctor. And, I would not say we offer primary care services. We are not primary care. And that's a very distinct thing in this market. There's a lot of companies that are out talking about virtual primary care. The reality is, we're not going to take a biopsy. We're not going to give you your vaccinations. There's a lot of things that can't be done virtually, but there are about 80% of things that can be done virtually. And, we need to really define that distinction as a market, particularly as so much has moved online, and that was accelerated by COVID. But I also think there's a lot of misinformation or mismarketing going on in this broader primary care market, where there's a lot that we can do that coincides with traditional primary care. But we never want to lose sight of the fact that at a certain point, diagnostics, procedures, things that are actually done in a brick and mortar office are necessary. And our goal is to be a virtual component to that broader ecosystem. How do we get the patients back to a PCP when they need it? There is a wide set of individuals who have very specific needs and ongoing maintenance that are not appropriate for virtual. And I think COVID really has highlighted what are the extents that we can go. And if we can't take it that far, how do we get them to the other gentleman on this call? Because I don't want to ever overlook that fact that at certain times you will have to go in to see somebody. And that's really the approach that we take. And how do we make that as a coordinated, efficient experience? How do we do data transfer? How do we engage in that? And that varies from market to market, payer to payer. But you know, I think it's a missed conversation in how people are looking at the market today.
That's great. Let's keep going on that thread to where you took it when that person does get back to the office, the physical office, or gets back in touch with their primary care physician. You know, Christopher, maybe why don't you talk about that patient-provider interaction and maybe how that is changing, or at least the consumer's needs and expectations are changing. I know in our prep call, we talked a bit about how you see changes with the millennials, both in their health status and how they use the health system. You want to give some comments there?
Yeah, you bet. Yeah, it was an awesome time to be in healthcare and certainly in primary care. I doubt we'll ever be on a roller coaster like that again. We in 10 days took everybody to virtual as well. And that went our core business, right? We were helping these physical doctors' offices move virtual, and we did it in about 10 days over like 6 or 7 different platforms. That's settled back out now to where 30% of the physicians' visits are virtual now. Again, our business is to help them with an extended care team and technology, pharmacists and nurses and care managers and clinical coordinators. And so we've been a virtual company extending the doctor for a while. But what was great is that the physician really appreciated those care team services a little bit more, because all of a sudden those care team services were the equivalent to their MA or their front desk person who was also working virtually. So now their entire physical staff of old is also virtual too. And, you know, physicians, us, you know, as a doc myself, I'll make fun of us, and we don't like to change much. I mean, we get a little bit flustered when we, you know, move the chair from the left side to the right side of the room. And so this was a massive undertaking. And what's great from a consumer standpoint is once the consumers got a hold of it, they were like, hey, we don't want to go back. They started to figure out, you know, whether it's 80%, 70%, or 30, whatever percent it is that you can do online, they started to figure out, hey, I want to start to explore that. What can I do online? Because they like the convenience of it, because they have it everywhere else in the world. And us docs have been slow to get to that. So the consumers, like always, have spoken. And so the physicians have now, you know, have just accepted that's the cost of doing business now in primary care. And that's great. That's great for the nation. You know, millennials, going back to kind of the point of, yeah, you need to go to see the doctor sometime. The millennials are interesting because they've been wanting this for a long time. And so this has been a big win for them. And we're seeing all kinds of interesting developments in them, that they're going to have a little bit of a higher burden of chronic disease than their predecessors. And so you're seeing, you know, these 40-year-olds show up with more chronic disease than the 40-year-olds that were when they were baby boomers or Gen Xers. So their shift to how do you have what used to be just a convenience of primary care whenever they needed to, now I have to establish a relationship long-term, and how might that be different in the future with video or text or these omni-channel different ways, but having to go in and having to establish a relationship. COVID did a great job, for better or worse, of making people realize how important their health was, because COVID attacked people who were unhealthy and overweight differently. And everyone figured that out and saw that happening. And the result is everyone's starting to want to have a primary care physician. There's a lot of national push for that. Employers are pushing for that as well, obviously, in their benefit designs more and more. And patients are starting to get it. Our year over year, going back from even 19 of new patient visits for establishment, not an acute visit, establishment, are way up compared to prior years. And so you're just seeing that that need of primary care more than ever, I think.
That's great. Well, let's transition. We talked a little bit about millennials. Let's go to the other side of the spectrum. And Roberto, with ClareMedica, you obviously focus on the senior population, Medicare members. What are you seeing and hearing from your patient base?
Well, it's a bit different. Obviously, we transitioned as well to virtual visits, certainly early on in the when COVID hit. But we kept our medical practices open and still saw some patients who wanted to come in. But what we saw later in the year is that, especially with the senior population, is that they want to see their provider, their physician. It's a little different. Certainly, virtual visits are here to stay, and it's certainly part of our toolkit now moving forward. But by the end of last year, our visits in the office in person were back to pre-COVID levels. And that's something that we've learned with the senior population. They need that social interaction more so than perhaps younger people. Visit to the physician is important for them. It's one of their more regular social interactions, and so it became necessary for them. We certainly have a great deal of outreach, and we stay in touch with our patients during COVID, even when they were not getting out. I think we did a really good job as a nation to scare the seniors into locking down, and they definitely did. But by the latter part of the year, they really needed to see their provider, and we believe that that's the best way to deliver care, certainly to the senior population. I think, as Andrew suggested, it's not virtual doesn't take the place of true primary care. It's an additional tool to maintain that touch point with your customer, and it's extending beyond just primary care in terms of other tools that we use to reach the patient in the home.
That's a great topic. I'd like to go there next, actually, Roberto, because frankly, the role of primary care is changing, and it can be different in different models. But you mentioned outreach, reaching out to these members, maybe taking care to their home. Can you expand on that? What does ClareMedica do that's differentiated to make sure that you're proactive with your patient base, doing things like outreach? I think we talked about in the prep call, even using licensed social workers as part of the model. Can you expand on some of what you've been doing that's innovating the primary care model?
Sure. Well, certainly with the senior population, it's extremely important to manage their whole care as a primary care. We view ourselves as the quarterback. But one of the innovative things that we've tried to do, and this is only one example of the different things that we're doing, is that we've partnered with a company that uses clinical licensed social workers. And we'll make referrals to them, and they will visit our patient, and they will effectively case manage them from a social worker perspective for 90 to 120 days. And what they do is they're viewing the home in terms of what their support system is, taking a look at those social determinants of health. As an example, we had a patient that had COPD and was making frequent trips to the ER and was not managing their COPD properly, even though they were under a very intense chronic care program. Well, we made the referral to the social workers, and they visited the home and found that the home had a roof leak and that there was water and mold building up in the home. Certainly in South Florida, that's a big issue for us. Well, it was that mold in the home that was causing that COPD to exacerbate and creating those additional visits. Well, those social workers were able to bring the entire family together and their entire support system to resolve that issue, get it addressed, whether it's community programs or what have you, and then manage that and fix that problem. And then suddenly they're in good health again. And that's not something that we would have otherwise known as a primary care physician if they visit the office. But by getting more in the home, we're trying to attack issues that are exacerbating or creating issues for the patient.
That's great. Christopher, maybe I'll pass it over to you and talk about how Catalyst is also helping evolve the role of the primary care physician, in particular through your use of technology, where you help expand capacity, you help change and improve the relationship between the provider and the patient. Can you speak to how you're using technology to enhance and expand the primary care physician's role?
I can give you a couple of examples, and I guess I should to walk into that. I think sometimes in some of the models of care that are out there, there are all these different models. Ours is a little bit more atypical in the fact that we are trying to expand the panel size of the PCP. We strongly believe that every American needs a primary care physician, that the results show that, you know, you live longer, you cost less, and you have more good days than bad. And so if we want to have thriving communities with healthy workers and healthy children that can, you know, learn to become healthy workers and productive citizens some days, then we really have to get everybody primary care. And there's just not enough of it. And so you only can do that through teams and technology. So an example of a couple of things we're doing, I would say, is through COVID. I'll use COVID again as a catalyst, I guess, pun intended in some way. Is that you know, we were down in the areas of complete health disparity, health deserts, grocery deserts, business deserts, where people do not have access to care, and bringing, you know, virtual primary care from the local region to them, where we can still deliver certain services to the home, like pharmacy, like medications, like certain services similar to the social worker program, and have that PCP quarterback to where there's not even any sites necessarily in those regions, partnering with community organizations, you know, the local YMCA or a church or an elementary school that acts as actually a community center. So being able to bring primary care to populations that don't have it, don't even have any funding. That's an example of what we're doing through our foundation work from a technology standpoint, just to reach a segment that has had just not been cared for at all, and doesn't really have a source of getting care other than, you know, the county hospital as a worst case scenario, which is not good on any of us. The other one is how do we put technology in the hands of the patient to do a lot of things in a more convenient way, and bring their own ecosystem of helpers, like their caregivers, their spouse, their daughters, their whoever, into the hand of a communication tool. And so our ability to have the entire care team that's named for the patient, you know, it's always, you know, Andy and Roberto and Michael and Christopher are always the ones, irrespective of what their payer source is, and to have that wrapped around in a wheel, so to speak, with their PCP, to be able to communicate with whoever you need to, and everyone be able to see that. A great example is that we kind of started during COVID because we had to, is you go straight into seeing a patient either virtually back then, but now it's more physically than not, just immediately transfer electronically to a pharmacist, and having your pharmacist, in fact, and that physician's pharmacist, and be able to communicate directly on what's going on with the medications, get those things synced up in the right way, and get them on a plan and a program right then and there, just lowering so many barriers in that way. And then I guess the final way that we use technology, which is really simple, and shame on us as a healthcare industry for not doing this, but we generally track our patients we generally don't track our patients in healthcare. We give people tick sheets and cards for our friends that are cardiologists, or tell them to go down and get an MRI and let me check this box for you. And you know, whereas Amazon is able to track our toothbrushes and toilet paper, you know, and get it to the door the next day, we don't do that very well. And so we put systems in place to be able to track our patients and see where they're going, not only for your traditional specialist referrals and services I mentioned, but also more than ever, you know, some of those social determinants of health, of when, you know, whether they're needing, you know, either food, transportation, you know, any type of financial support, and then even atypical things like chiropractor, you know, yoga, you know, things that definitely could be beneficial. They're outside of your traditional maybe medical norms, but what people are caring about and what people are wanting to actually try to help them in their own self-care. How do you track that and make sure that's visible to all?
Great. Andy, anything to add from your end? I'm sure there's some parallels relative to Christopher's comments around local regions where there's frankly not enough care. The ability to bring it virtually increases access. But anything you'd add from the technology side at SiriusMDs and your ability not just to expand access, but to improve the care delivery that the primary care physician can deliver because there's that added resource available to the patient?
Yeah, absolutely. I mean, I agree with absolutely everything that Dr. Crow said. I mean, but the reality that we face as a society is pre-COVID, we had about a shortage of 60,000 primary care physicians, each of whom cover a panel of 2,000 to 4,000 patients. And we have lack of access to care. And there's a lot of equity components to who gets access to those doctors as well. And we do a lot of work in Medicaid. We work in Medicaid in Louisiana, for example, and they just don't have access. And they have clinical needs. They're, a lot of very sick people who literally can't get in to see a doctor. And, how do we serve as a bridge is really how we look at it. We don't want to own the primary care relationship because as our colleagues on the call well know, and as Dr. Cripp pointed out, there is a need for that relationally driven care. Our goal is how do we serve the needs of those who don't have access to the care? And how do we bridge them into an environment, particularly those with more severe needs, where they can get that care? And we can do that using technology. And, the reality is we're empowering large insurance companies, large employers. They all have care navigation, care management, chronic disease management, pharmacy programs that are available. But, you get presented with a list of 100 phone numbers. How do you get to those? What we're trying to do is how do we make this simple? You connect to a doctor, they can navigate you to all these other resources that your payer, whoever's financially responsible for you, has already invested in you to bridge that gap. And that's a big component of what we do. I mean, we provide care directly. We have the National Physician Network, but at the same time, we want to tie your care back locally. And I believe that's critically important. And as we have more pharmacy options and other things, how do we make that as seamless as possible for the user who maybe isn't mobile, who doesn't have a great payer dynamic because they're on Medicaid, or, and a lot of the large insurers or employers that we're working at, companies like Target, they have hourly employees that have no insurance. And they're starting to begin to provide this. And if you have no insurance, you likely are not going to have a primary care doctor. So how do we even begin to engage them in conversations around their health? Behavioral health has become a huge concern. That's something that we also bridge into. And I think the beauty of doing things virtually, while it's not a fully comprehensive solution, we can bring way more resources to bear from a single access point in a very efficient manner for the patient. But then we also need to be able to coordinate with organizations like, the other folks on this call, in how do we tie that back for the patients that really need that? And so it's a little bit of a different thought point and positioning in the gaps that we're trying to cover. But the reality is there's this continuum that everybody sits on. And we need to be able to provide care and fill the gaps in the continuum. And that's really the way we think about our role in this market, which I don't think virtual care as an industry has done a very good job of identifying themselves as that. But it's how we think about the world.
Got it. Well, it looks like we may have a question from the audience. Michael Carroll?
Yeah. So gentlemen, there's a question around the role of the family caregiver, and how do you think about the relationship between the family caregiver, the patient, and the primary care physician is the first question. And then two is, are you doing anything now that's kind of tightening that relationship between the patient and the family caregiver so that there's a navigational part to their role?
Well, maybe
Someone
that's
want to take a first shot at that?
it's probably more so the case, with seniors is making that connection with the with the family. In our case, a great deal is with the kids. And because we're in Florida, a lot of these kids are in some other part of the country. So, you know, a lot of times the seniors here in Florida are on their own. That's one of the things we try and do, you know, upon that first visit, is to understand their family dynamic and their local support system. Who are they relying on as their connection? And I, you know, I revert back to that social worker. You know, that visit to the home helps us establish a great deal about that relationship and knowing who to reach out to. And our care managers, who are constantly interacting with our patients, are always trying to follow up with the kids or whoever else is part of that support system, and identifying where there are some gaps that they need some support, and when things have taken a turn, we're going to try and keep them up to date so that they understand when we're going to need their help. And we also encourage them to check in with us on a regular basis so that if they want to see how their parents are doing or how their family member is doing, to make sure that they connect with us, because that support system is very important for that care. It's that social network that I was mentioning before. They need that interaction, and that interaction helps maintain, as Dr. Crow said, more better days than less better days.
That's great. Any other perspectives on that question?
Yeah, I mean, just from a purely digital perspective, there's a lot that can be done around proxies, and you know, there's a lot of complex laws around how this can all be done. But you know, the reality is we oftentimes, whether it be a senior or a child, have another individual acting on behalf of that individual. And there are things from a user experience thing that you can do virtually that enable that in a legal and kind of efficient manner, where it can be very intuitive to allow virtual care to exist, even for somebody who may not necessarily be able to engage in that themselves.
Great. Yeah, that's really interesting. But maybe we can a little bit take that thread a little further and just think about other uses of technology beyond just enabling that virtual visit. I'd be interested to understand whether it's part of Roberto, part of kind of collaborating with other groups, such as the ones bringing the licensed social workers into the home, or Christopher, whether it's collaboration between different provider organizations that are part of your integrated network. How else is technology being used, or do you see technology being used to continue to enhance the primary care model? Christopher, maybe you want to start with that question?
Well, I mean, yeah, there's a, yeah, it's a great time to be in this space, because it's just, there's so many creative options that there's a lot of ways you could skin that cat, and kind of from a low hanging fruit. I would take, to add to where you were, I would take, look at us here on the screen, right? There's 4 of us here on Zoom. And so as you go back to the prior question about the caregiver, you know, we think of the caregiver as part of the team. Usually they're a significant decision maker. So from an efficiency of technology, you know, right now we're having synchronous communication in video where you can pick up, you know, tone and body language, which is super important, especially in some of the, you know, all of Claire Medical's work, a good portion of ours, because we're in that not only chronic disease, but Medicare Advantage and Medicare work as well. And to be able to see someone's surroundings and what's going on with them, and their caregivers give inputs is huge. Once you have that, then the asynchronous communications can be a lot more effective as well. So just this combination of synchronous, asynchronous, having the ability to put multiple people with different acumens on the screen at the same time to have a meeting, which is something we never did before in traditional fee-for-service world. There is no payment for care coordination in fee-for-service, but when you start taking, you know, global risk or even partial risk or cap, or you're paid for an episode, then these technologies that have been around for a long time start to make a ton of sense operationally to your business model, and it brings in all the stakeholders to a value prop that we just didn't have before. So I use, like right now, what we're doing as a great example of pretending that, you know, you're the patient, and we make up your doctor and your social worker and your dad, or your son, and we're all trying to take care of you. I mean, that's the kind of stuff that happens all the time now, that is very simple, yet super impactful.
Roberto, what do you see in your provider and patient base, where obviously you've already mentioned, these seniors, they want and need to be in person with their provider, but how are you leveraging technology, or how do you see yourself continuing to leverage more technology over time to integrate all of the different activities around that patient, especially given that you are a risk provider and you're not just concerned with that primary care visit, but all aspects of their care and their health?
Well, I think one of the things that we've benefited from is, some of these targeted programs, like the one I talked about, licensed social worker, or it's a hospital at home, or any of these other programs. We have real-time connectivity with them when they're seeing our patients. So we're getting real-time data on that visit, on that referral. I think putting that real-time information in the hands of the primary care physician and the case manager, care manager in our office is very important to manage. In the past, you probably had to wait for a visit, get a written result or a consult. Perhaps they mail it to you a week or two later, and then you're reacting 3-4 weeks after the encounter. We're getting that data immediately, and we're able to monitor and manage that care using that feedback. In addition, the people that are out on the field, so the people that are actually visiting, whether it's a social worker or an ER trained nurse practitioner in the home for hospital at home or whatever it might be, have instant video connectivity with their support system as well. So that if a nurse practitioner is in the home and needs the support of an ER trained physician, they can do that via video connectivity with the patient at the home and deliver any therapeutics at the moment. So that is instantaneous. And again, I think that's facilitated through technology. And then ultimately, if you're going to really manage their care long term and improve their care and improve their well-being, it's capturing all that data and bringing it back to the primary care physician so that he can see the whole of what is going on and make care decision based on that feedback. And that leads to more analytics around and more predictive modeling in terms of what we think about technology is providing these tools and providing this data and providing this input so that the primary care physician can then make these types of decisions in what's best for them and bring all these tools to bear. That's how we view the use of technology, and I think it's very exciting.
No doubt. And I think the way you framed it, Roberto, is right. It's that the power of what the primary physician can do in that moment when they're enabled by the real-time data, they know everything that's going on with their patient, that we've never really had this opportunity before now. So I think it's exciting times. Maybe one thing we haven't touched on though, and maybe Andy, I'd be interested in your perspective, if you have we are asking physicians to do a lot, now there's more data to review. You might be jumping from an in-person visit. Perhaps you're now juggling that with virtual visits in between. What's the provider's perspective on the use of all this technology and what's being thrown at them?
Yeah, I mean, to me, the big component of that comes down to payment models. How's the physician being compensated? And are you just layering technology on for data capture to bill better? Or what we see is physicians want to provide more care more efficiently. And that's across the board. That's how my co-founder thinks about it. He's an ER doctor, but we employ a wide range of across a variety of specialties of doctors. And when it comes down to it, is the technology to enhance billing in a fee-for-service model getting in the way of their ability to provide care or creating inefficiency, or are we enabling them to provide more care? A lot of the doctors that staff our programs are, recovering family practice docs. They sold their practice to a big hospital system, and the, data requirements of billing became too much. They just didn't like practicing in that mode, and they want to be more efficient. Doctors invest a lot in their career, in their training, the debt that they take on to go through medical school, and they're now entering a market where everything that they really do is about how do we generate a bill. in terms of the leadership and guidance that they're given. Well, that doesn't align with how do we provide more care more efficiently? How do we coordinate care better? And it really goes down to how do we, we've been talking about value-based care for over a decade. By 2020, it was meant to be 80% of the market. Didn't happen. And that's because there's a lot of vested interests not wanting to make it happen. But if you can free a doctor and say, hey, we're going to pay you a salary, we're going to pay you on a shift basis, we're going to pay you however that doctor wants to be compensated for the work that they're providing, and we're going to free you from all of the billing. You have to document. There needs to be an ability to provide continuity. Part of the issue broadly is how do you get that primary care doctor an awareness that a virtual visit took place in the world that I live in anyways. And we have some customers where they've established their own HIEs, and every primary care doctor that's affiliated with that insurance network is on it, and our doctors are on it. And every time somebody has a virtual visit, the primary care doctor is notified, and they're aware of what's transpired with one of their own patients. The most advanced version of that payer, dynamic that I've seen, it all happens automatically, and the doctor doesn't have to think about it. And that's where we need to strive to. But the problem is the payment models and the data systems are not pervasive enough on a national basis or even on a regional basis within the United States yet to make that as effective as possible. And so for the more narrow network approaches, you can do that within a closed network. How do we begin to expand that? We work with the Uniteds, the Aetnas, organizations like that, where they're operating across networks. They're all on different EMRs, and even the EMRs of some of these large health systems don't communicate with themselves. And so there's a lot of problems in, data transferability. But ultimately, if we can solve some of the payment dynamics to make that better in terms of thinking about continuity of care, thinking about referral patterns, thinking about what is the broader care team that needs to have this data to work with the patient on whatever their medical concerns are, is the fundamental underpinning of why that hasn't really happened, because most of healthcare today has taken I'm going to close the moat, I'm going to keep my patients, I don't want anybody else to know about it. Well, that's great, but sometimes your patient goes to the urgent care up the block. Do you want to know that happened or not? And how does that tie into whatever their medical conditions are? That has been completely lost, and it's really a failure of payment dynamics in my mind.
Got it. I think it's a really interesting and just continued thorny problem to solve. Obviously, Christopher, I'd be interested to hear what you all are doing across your, I think, 1,000+ physician clinically integrated network. Obviously, not all under one organization's roof, but integrated clinically. And I believe you have some innovative partnerships, including with Baylor Scott and White. How do you tackle that problem of managing coordination, communication, data, and even risk enablement and the payment flows to the extent you participate in that?
Not easily.
I just asked you to solve all of healthcare, but we'd love to hear what you're doing today.
That's pretty hard. So I will double down on the biggest issue we have is in payment models. The best example of how payment models work is when COVID happened and we weren't able to go into our offices and everyone moved to virtual because that was the only payment model available. That shows you the power of payment models. We don't have the right payment models for primary care. If you really want primary care to do what it can do, the promises that we talked about around longevity and cost, we have to pay for that. And that's more of what we would call a subscription-based or longitudinal type payment to get to the type of activities for us to be on Zoom and use the technology. Your question before was around how do you get the physicians to use the technology? Well, it starts with the payment model. It can't interfere with their finances. It can't interfere with what they think they're doing clinically. It can't interfere with their time in terms of extra time unless it's connected to financial or clinical improvement. And most importantly, it's got to, whether they like it or not, we all have our egos, and it's got to be something that they get feedback from the patients around them to say, hey, thanks, Dr. Crow, for hooking me up in that way with your pharmacist and the care team. That's really cool. When I hear that, it makes me want to do it again, right? Because we all want that dopamine squirt of affirmation. And so that's a big piece of this. And so all of that gets into your broader question of that healthcare absolutely, and Andy mentioned it a second ago, it's a team sport. It's a community sport, and fee for service creates silos of care. There's nothing in fee for service to coordinate care. We've done some bundled stuff, but CMS has done a lot better more recently with Medicare Advantage and now DCE, and really pushing the ball forward on things that force us to collaborate. Employers are talking about it. They're scared to death because of the talent, the war on talent that's there to make too many changes and to narrow networks too much because the perception of what would happen if Americans thought that their choice was being taken away from them, even if it's going to cost more. So, what we're doing with Baylor, for example, is if I'm in primary care and I'm ultimately going to be managing total cost of care, and maybe I should be, and maybe we are the tip of the spear, then I'm going to need downstream partners. And there are health systems across the nation that are fully integrated, and they've been there for a while. We've continued to have massively increase of costs year after year after year. So I guess that didn't solve it. We've had PPOs. That didn't solve it. We've had deductibles. That didn't solve it, that the consumer was going to solve it for us. So now we're kind of in this moment of primary care being hot, as you mentioned in your intro. And so can primary care be the savior foundation of the future for us? And to do that, it's going to be a lot of data, a lot of technology that supports relationships, and a lot of collaboration in communities to make things happen. And so what we're trying to do with Baylor is say, hey, you do these things well, we do these things well. We both focus on the same geography communities. How can we work together to bring real value to our communities? Because we ultimately are in the purpose business of helping our communities thrive.
That's terrific. Thank you for that, Christopher. Michael Carroll, looks like we may have another question from the audience. You want to chime into the group with?
And I think it's a follow-on to what we've been talking about, but I think there's a curiosity from the audience around how do you think about the ROI of care management? And so think about that as an enabling capability that makes primary care work and connects the system. Like, how do you justify an expenditure in that? How do you think about calculating ROI? How does that fit into kind of the collaborations that you may have in the market? So any one of those topics.
Roberto, maybe I wonder if you would mind starting, because I would think that care management model is pretty threaded into how you manage your patient panels.
Yeah. Well, so obviously we are responsible for a significant amount of dollars being in a value-based arrangement, both with MA plans as well as with directly through participation in ACOs and now with Primary Care First. So it's an important consideration. That's why we can make the investments we make, because there are, look, at the end of the day, all we're doing is taking advantage of the inefficiencies in the system. There's a significant amount of dollars out there, and we can provide and care for our people for a lot less of it. And so we're able to make those investments, and I think that ultimately the patients are the beneficiary of that. To the extent that we're effective, the MA plans can then spend more of their money on benefits, and the expansion of benefits benefits the ultimately the consumer. So we make those investments because there's real dollars available and to be made. Like your slide showed, there's a significant amount of financial transactions in this space. There's a significant amount of investment. They're doing that because they can see that they're, long term, there's a significant amount of value there in terms of what we do, and we take those dollars and invest them, and we're getting a healthy return on that. So the system makes sense. As Dr. Crow said, the payer models were broken before, but I think we've found one and value-based, that makes a lot of sense. Everybody's invested, and you know, you have the financial capability to make the investments in the technology and in the care management programs.
Great.
Yeah, I guess I could
Go
add
ahead.
on. It's a question we hear a lot. And I think if you're coming from the last 15, 20 years of care management, for one, that's a very broad definition. I mean, that you could have a lot of different people say what it is. I mean, it's like saying, what's primary care? You heard about 6 different models at the very beginning of primary care, even. You're seeing 3 different ones right here. I'm getting a little bit of feedback. You guys are all of a sudden.
Sounds okay to me.
Okay. So care management for us, I guess I would remind people, it's integrated into the physician-patient relationship. And care management, the way it's been the last 15 years, has been through a payer and parallel. And there has not been any return on that. You know, having your BUCA insurance companies do care management in complete parallel and zero integration with the physician and the patient, it has no ROI. Employers have been wasting money on that for years. And so, yeah, what you're trying to do now is bring that into the primary care relationship. And now, inside of care management, what is in it? Define it for your particular model or our particular contract. You know, ours includes, pharmacy. Pharmacy all of a sudden is something that's really exploding in cost. So having something that manages the adherence and the management and the delivery and the dispensing and all of that inside of that care management is super valuable. Tracking patients in the way that we do is super valuable. But so it's got to be how it's actually organized. Does it bring you, operational improvements, through better clinical markers, which then leads to lower costs? Are you freeing up more of the physician's time so they can work to the top of their license, or freeing up their more time so they, will adopt more of that care management to begin with? So there's just kind of throwing out I think care management doesn't have a good ROI. I completely agree in the past, in the parallel way that the payers did it. And now the question is the way Roberto said, is like, yeah, they know what the investments they're going to make, because they know where the care management team is helping their patients and how the technology is going to afford them. So they'll keep investing in that because it provides ROI. And so will we. We've saved over $100 million the last 5 years because we have this platform that's operating, that has certain specifics of care management as a broad category.
Great. I think we have time for probably one more topic. I'd love to talk about disruption in primary care, disruption to the consumer experience, to the provider experience, to collaboration. And I think it's a market that generally has been marked by incremental changes. COVID and the overnight change to virtual visits was obviously massively disruptive. But as we go forward, I'd love to hear any predictions. Where do you see in the next 5 to 7 years, where do you see the most likely disruption to occur? What does that look like? And how is it going to fundamentally change how the consumer experiences primary care? Who'd like to go first?
I'll take it. It's a really interesting thing to think about. And again, as we've all been talking about, a lot of it's going to come down to payment models. And the reality is CMS dictates that, almost all of healthcare is done on a percentage of Medicare. There's obviously exceptions to that. And, as long as the powers that be, effectively Congress, are willing to put forward better risk alignment, that will drive most of the change. And we haven't seen that change as much as it could have. Obviously, there were components of the Affordable Care Act that were aimed at that. But ultimately, how do we incentivize better coordinated care? To me, is the most critical component, because then that opens up the possibility of what can we now do with technology? How do we allow patients to have omni-channel access, whether that's in a clinic, in a hospital, virtually on their phone, on their computer? How do we enable all of that in a very coordinated fashion? Because if the payment models come into line, you will all of a sudden start to see much more data interoperability. Obviously, there's been a lot of federal pushes towards that, but we really haven't made as much progress as we should. And a lot of that comes down to economics. But once you have full data transportability across various providers, the broader ecosystem, you can then start to plug in devices. A lot of people love to talk about, well, a patient will have a device at their home. Well, that's great, but if the broad care team that's trying to assist that patient with whatever their medical needs are don't have access to it, is it even meaningful or useful? And, how do we then use those types of data points to drive awareness within a care team that, hey, this patient's going through an exacerbation of whatever their condition set is? And how do we make that become a more proactive outreach? I mean, my view for telemedicine is almost like a CRM. How do we cohort patients and become proactive versus reactive? And now that we've connected you with the doctor, how do we tie that care back into a broader community to make sure that you're getting a full closed-end loop of care for whatever your needs are? And that's very general, but a lot of it does come down to payment dynamics. And there's a lot of innovation going on in primary care. Unfortunately, the investor market has started stepping up to fund these types of things, because we need to rethink the entire way that it works. But it all boils back to CMS Medicare rates. And until we have improvement on that, things will continue to stagnate, in my opinion. But I think COVID has at least opened a lot of eyes that things can be done differently. They should be done differently. How do we want to think about parity between virtual versus, in-office care? How do we want to think about incentivizing various types of providers who are not necessarily within the same practice to work with one another? There's a lot that can be done. And it's not a technology gap issue right now. It is much more a market dynamics issue.
Great, thanks for that, Andy. We just have probably 1 or 2 minutes left. Christopher or Roberto, would either one of you like to offer a prediction on the type of disruption we might see in the years ahead?
From my perspective, I think that you're going to see, I think Andrew talked about it with respect to payment models. I think groups like ours that know how to manage in a value-based environment, know how to manage specifically the senior population, will be contracting directly with the government to manage cohorts of patients. No more third-party intermediaries. We'll be able to bypass an MA plan. We'll be able to bypass even an ACO. We'll be participating in DCE or some derivative of that, where we're just managing a population based directly with the government, and we'll be get paid directly and manage that payment. And then that'll see even further investment, because in order to manage that effectively, we're going to want to invest more in technology and care management programs, because we know what's going to have the impact and what's going to benefit, where we're going to get the quality results. And that's ultimately what we all care about.
Great, thank you for that. Well, gentlemen, I think we're out of time for the day. So I think we're going to conclude our panel discussion today. Thank you very much, each of you, for participating and bringing forth the unique perspectives of your organizations. It's been a lot of fun, and I'm sure our audience has enjoyed it as well. So thank you again. With that, I'd like to bring Michael Carroll back up on screen for concluding remarks.
Great, gentlemen, I'll echo Michael's thank you. We appreciate you joining today. Great conversation. That concludes today's Market Insights Live. And actually, this concludes our actual spring series of Market Insights Live. So we're going to take a little bit of a hiatus and come back in the fall with a whole new series of panel discussions focused on innovators, investors, and strategic players across healthcare. A reminder that you can view a replay of today's Market Insights Live session on our website. And you can also find a podcast for today's session on your favorite podcast channel. Again, thanks for joining us, and have a great rest of the day, and we will see you in the fall. Bye-bye.